Well, hello, good evening. Welcome to this inaugural webinar of our Women's Heart Health Series, organized by the GW Heart and Vascular Institute. We are so happy to have you all here with us today as we launch this new series during the Heart Month. My name is Dr. Gurusher Panjrath. I am the director of the GW or George Washington Heart and Vascular Institute. I'm also a professor of medicine and direct the heart failure program. The GW Heart and Vascular Institute was founded in 2001 as an academic institute within the GW University School of Medicine and Health Sciences. The three pillars of this institute are focused on research, professional medical education, and community service. We leverage both our clinical and academic expertise to foster collaboration and innovation, drive impactful change, and inspire a healthier and a more equitable cardiovascular health for all. For our first webinar today, which is titled as Cardiovascular Disease in Women and Identifying Your Risk, I will be joined by two of my fabulous colleagues, Dr. Dorys Chavez and Jannet Lewis. Let me introduce them to you and then I'll let them take over. Dr. Dorys Chavez is a cardiologist and a cardiac electrophysiology fellow at our institution at George Washington School of Medicine and Health Sciences. She completed her training here. She did her internal medicine as well as cardiovascular disease fellowship at GW Hospital, and now is pursuing her training in electrophysiology with a very strong clinical and academic focus on cardiac arrhythmias, device therapy, and other electrophysiology-related things. She has an extensive experience in global cardiovascular health, including a long-standing participation in medical missions, providing pacemakers and defibrillators to underserved patients and populations in Honduras. She's also engaged in research with numerous peer-reviewed publications, book chapters, books, and presentations at both national and international meetings, spanning a whole host of topics in cardiovascular medicine. She's a member of the Alpha Omega Alpha, which is a prestigious society, a current fellow of the Heart Rhythm Society, and has received multiple awards, including Fellow of the Year Award at GW, American Heart Association scholarships, and recognition from the National Hispanic Medical Association. She's passionate about education, mentorship, and in advancing equitable cardiovascular care through her excellence. Welcome, Dr. Chavez. I also have Dr. Lewis, who is a long-standing colleague of mine. Dr. Lewis is a professor of medicine at the School of Medicine and Health Sciences. She's the immediate former director of the non-invasive cardiology lab. During her tenure, she built and developed the non-invasive services through excellent patient care, as well as through fostering a very excellent academic environment. She has been a mentor to generations of students, residents, fellows, and who, she has left a big mark on. She's also worked to provide cardiovascular care specific to women, and hence she'll be a great asset here today, educating both lay and academic communities and engaging in research to the care of women. She's a fellow of the American College of Cardiology and actually has served as the governor of Washington, D.C. chapter during her tenure. She's also a member and actually a former board member of the American Society of Echocardiogram. She's extensively published as well, including publications, book chapters, and on areas such as echocardiography, as well as cardiovascular disease in women. Today's webinar will begin with a short presentation from both of them. I'm going to actually hand it over to both Dr. Lewis and Dr. Chavez to say a few words of welcome, and then they'll share some slides on background information about women and cardiovascular health. And then after their presentation, they will have a discussion and they'll open the floor to questions, and you're welcome to insert your questions in the Q&A chat box. Again, thank you for joining us today and spending this valuable time of yours with us. Welcome again.
So, Dr. Panjrath, thank you for that glowing introduction. I appreciate it. And I want to thank each of the participants that are signing in on this Wednesday. I'm hoping that you'll find our presentations are very short because we wanted to make sure that you had enough time to ask some questions. And Dr. Chavez and I will do our very best to answer them as well as we can. This is a subject that is one that I've been very interested in probably for certainly for over 20 years. Um, we've moved along and have increased the awareness for sure among women about the impact of cardiovascular disease. If you ask the average woman, even 10 years ago, what was the major cause of death in women in the US? Many would say breast cancer. But in fact, cardiovascular disease is the most common cause, both in men and women, with nearly 1 million deaths in the year. It claims more lives than cancer and respiratory disease. There's a higher prevalence of cardiovascular disease if one includes hypertension among African Americans. Cardiovascular disease, particularly deaths, are most commonly coronary artery disease in nearly half, and the others you can see listed there. So again, number one cause of death, these are just from the American Heart Association, which tracks these things. And you see just the number of heart attacks that occur. Now, while women tend to have fewer heart attacks than men, and we'll talk about that a little bit, the mortality actually tends to be higher, and the recurrence rate within the next year tends to be higher. Women are usually older when they have their first heart attack, usually about 72, whereas men are generally about 65. This does not mean that younger women don't have heart attacks. Um, However, we'll talk about the risk factors, and I think these are particularly important. Now, there's some things in life that you can't change, your family, for example. So, family history turns out to be a risk factor for heart disease. But, if you have an 80-year-old parent or grandparent that has a heart attack, that's not a risk factor for you. The risk factor occurs when the disease occurs earlier in life, younger than 65 for a woman, 55 or less for a man. The major risk factors we've identified for years. They're hypertension, which is very prevalent, elevated cholesterol, importantly, diabetes, which is on the rise, and cigarette smoking, which has declined over the years. But you still have about 10 to 15% of women that smoke. So it's pretty impressive. I have to tell you that I can count on maybe one hand. I've been practicing for a while, one or two, that it is very uncommon to see a woman under the age of 65 with a heart attack unless she smokes or has diabetes. The prevalence of these risk factors varies among the population. So hypertension is highest among Black women. LDL cholesterol, the cholesterol that's related to the development of coronary disease, is highest among white women. Diabetes in Hispanic women. And we all know that overweight and obesity has kind of reached epidemic proportions in the United States. All of that being said, smoking and hypertension are the leading factors that lead to disease and mortality. Almost half of women that are over the age of 20 have hypertension. The prevalence of hypertension increases as you get older. There has been, over the last several decades, a gradual decline in cardiovascular disease mortality, which is great. This has been in part due to differences or changes rather in treatment, but in large part to some changes in lifestyle, in diet, and prescription for exercise. That being the case, we've noticed a plateau in the rate of decline. And in fact, in younger women under the age of 50, there seems to be actually a slight increase in the mortality. So those markers are not ones that we want to see. And we still have persistent disparities by race and ethnicity. Now, so we talked about those general risk factors, but there are differences, and that's why you're here today to hear about the differences in coronary disease, the blood vessels that feed the heart, among women. Women tend to be older. We talked about that. Because we're older, if and when we have coronary disease, you tend to have other diseases uh, that impact on the overall mortality. There are differences in the initial manifestation, but I want to point out there's been a lot in the media about, and women have different symptoms when they have heart attacks. I think that's misleading. The vast majority of women who have coronary disease, either angina or a heart attack, will have some kind of chest discomfort. Now, what is different is that women tend to have other things, nausea, fatigue, shortness of breath. But most individuals will have some kind of discomfort in the chest. Can I have the next slide? Yes. Now, there are some things that are unique to women. I think that we missed one of those, but so women that have hypertension, or during pregnancy, or preeclampsia, or eclampsia, are absolutely at higher risk in the next 10 to 15 years of having some kind of cardiovascular issue. This turns out to be really important because where do women usually get their care till they're older? They get it from their OBGYN. So we've had some efforts at GW, for example, to try to get together with our OBGYN colleagues and funnel these women into cardiology or into medicine because they are absolutely at risk. This does not mean that if you had a hypertensive event or if you had preeclampsia, that you're going to have one of these things, but it means you're at risk and you should be monitored, especially hypertension, and managed appropriately so that in the 10 to 15 or more years, you don't develop these abnormalities. So here's some more risk factors that are unique to women: early menses under 11, premature menopause under 40, importantly, polycystic ovary syndrome, which is associated with high cholesterol and hypertension. Those patients are predisposed to have coronary disease and often at a younger age. The other things, less important, we don't see too much of the amenorrhea, and oral contraceptives as well as hormone replacements have changed tremendously over the last decade or so. So this turns out to be less of an issue as well. So when I see a person come into the office to see me, what they want to know is, what is my risk? How do I determine my risk? You went over all the risk factors, but is there any way I can get a better idea of what my overall risk? And I do this calculator because people like numbers, especially doctors, but patients as well. This calculator helps you predict. Now, obviously, there's no calculator that can predict with 100% certainty if someone is going to have an event, but we can do a pretty good job of determining who is high risk. So this calculator actually has only been in use for the last couple of years. The American Heart did a very large population-based assessment with over 6 million people. And the calculator is important because it helps you to decide. For example, I have individuals who are very reluctant to take any medications, for example, for their cholesterol. And so we sit down and we go over what the risks are, and we try to determine if the person is low risk, and we can continue with some things that Dorys is going to talk about, so I won't talk about that, or whether I'm going to be a little bit more convincing in trying to manage those risk factors. And this next slide shows what this is basically available on the computer. And what you'll see is that it's all the things we talked about. So age turns out to be a very, very powerful predictor. The older you get, the more likely you are to have coronary disease. The cholesterol you see is included in this, both the total and the HDL. Blood pressure plays a very big factor. Body size, measured here as the BMI, and kidney function, that GFR. You also see that you can expand it to diabetes, whether or not they're on medications, and some other social input. But this is kind of the general format that I like to use in almost all patients. So just to conclude with this, the mortality for coronary disease, for cardiovascular disease, has been falling for several decades, but we're starting to see a plateau in that decline that is bothersome. Cardiovascular risks are very common and they're prevalent in women. Importantly, hypertensive disorders of pregnancy predict subsequent hypertension and events, cardiovascular events, so should be followed over the ensuing decade or so. If we're going to reduce cardiovascular mortality, it has to be a comprehensive approach. It has to be one for prevention. I think we've all gotten better with recognition, both women as well as providers. And we need to be more aggressive about management. I won't share these data today, but there are pretty clear-cut data that show that women, for example, get less statins. And a big issue, also not a subject for today, is health access. So that's it for me. The next is going to talk to you is Dr. Chavez. I have been practicing for quite some time, and the thing that has brought me probably some of the most gratification is the ability to work with young, brilliant physicians. So I'm happy to hear from Dr. Chavez.
All right. Thank you, Dr. Lewis, for such a wonderful talk. And Dr. Panjrath, thank you for the kind introduction that you provided. Good evening, everyone. Welcome. Thank you for joining us tonight. And we truly appreciate your time today. So it is humbling to me, and as Dr. Lewis was pointed out, how much we have advanced in medicine, how we move from ancient wisdom, the ancient philosophers, to how we practice medicine. And even in my short career of medical field, I have seen that transition, how much medicine has changed. So if you think about it, when we started with the philosophers, everything was about observational. We just wanted to watch who will get sick, and getting sick was about fate. As we transitioned in the early 20s and the early 19s, when we started the industrialization, it was more about cardiovascular disease, but we started noticing what were the problems. We started checking more. We started discovering that if checking our blood pressure and it was high, that will create a problem. Who was at risk of developing plaque inside the arteries and leading to atherosclerosis. But what changed everything was mid-20th century. That's the Framingham study. And that's what led to the risk factors that Dr. Lewis nicely was pointed out to us. Who is at risk and what are those risk factors that lead us to heart disease? And that's where we get the data, based on evidence that how high blood pressure impacts our life, how smoking impacts our life, how obesity leads us to more heart disease. And now we're changing a little bit the focus. And, as we grow out in this field, as what Dr. Lewis was pointed out, now we're not only treating the disease itself, the focus is like, who is at risk of developing this disease? So we're trying to be more precise, and we're trying to prevent the development of disease. And that's where we have, progressed over time, that before it was a curse to get sick, and now we're trying to prevent the disease by minimizing those risks. Next slide, please. And how do we do that? Well, our tools has gotten better too, our medical field has gotten better. So now we have technology-driven prevention imaging, such as in the images that we have here. On the top right, we see a coronary calcium score. Okay, so what this helps us, and each patient has their own indications about this, but this provides us patients who are at risk of developing atherosclerosis. It gives us a better images about how much of that calcium or how much of that plaque is actually causing problems and who will develop later on more risk. We also have on the top bottom, sorry, can we go back to the slide? Thank you. The cardiac MRI, and that gives us a better idea of the anatomy of the heart, inflammation of the heart, and even, how is the heart functioning as well. So now our tools has gotten better. So now we talk about technology-driven prevention. Next slide, please. And this is a slide that I want us to, all of us, it's always a good reminder to keep that in mind. Probably we have all heard about this, but unfortunately, we don't follow all of these pillars, not even in our own medical professional field. If you see here, these are the pillars of cardiovascular health, okay? And this is all based on evidence. This is the pillars to prevent cardiac disease. So what we have learned so far is that having a healthy diet, and there have been multiple trials, that following a Mediterranean diet or a DASH diet or a fish diet, that prevents the risk of cardiovascular disease over time. Regular exercise. What do we talk about regular exercise? How much is enough? And, what type of exercise? So the guidelines say that if you do 150 minutes of exercise a week of moderate exercise, then that gives you cardiovascular prevention and cardiovascular health. It is hard with the schedule, with the work, with the timing, but at least if you think about it, you can adapt your routine and do 15 minutes of at least cycling or walking every day, or instead of taking the metro or the bus or driving to work, then you can actually accomplish that by walking to the metro or walking to work if that's suitable for you. We talk a little bit about how obesity is one of the risk factors too. So having a body size, that is within normal limit helps you prevent. And more importantly, we never talk much about this, but stress leads to inflammation, and unfortunately has been associated with a higher risk of cardiovascular disease. So stress reduction helps you minimize cardiac disease. And sleep quality. We're talking about 6 to 8 hours of good, well-rested sleep. And that's why now we're even doing studies to see who is at risk of developing conditions such as sleep apnea that puts us at risk of heart disease. So I just want you to keep in mind this slide, because this is our pillars to keep in mind how we can prevent the disease itself by doing things on our own without involving medications or even technology to prevent that. Okay, next slide, please. As we were talking about, our medicine has gotten better and our biomarker has gotten better. So we have different blood tests that now identifies, based on your family history and based on the criteria, if you meet that criteria to get that biomarker. Now we have more blood work that is more sensitive to detect who's at risk of inflammation, such as the high sensitivity CRP. We also have better biomarkers for cholesterol detection, like the ApoB or the lipoprotein A as well. Next slide. And, this is my slide. I focus mainly on arrhythmia prevention. Now, the technology that we have available, to look at symptoms in stroke prevention and cardiovascular is admirable. Now we have smartwatch, as you can see. Most of the smartwatch now come with a tool that you can actually get a 12-lead EKG or even a rhythm strip just to check your pulse, see how your pulse is doing, if it's too slow or too fast. Okay, now you can actually get online portable EKG monitors where you just put your thumbs, you put it underneath your phone, and that actually gives you an EKG. So if you're feeling, skip beats or palpitation, that also gives you some. Now we also have monitors that look like Band-Aids that you can wear for a week or for 2 weeks, and actually gives you an idea about, when you're exercising or when you have symptoms, to see how much of your pulse is varying, or if you have, arrhythmias. And sometimes, 2 weeks is not enough. So sometimes we implant monitors that are like a pill size underneath your skin to watch you for at least 3 to 5 years as well. So next slide. So as you can see, in a nutshell, we saw how we have progressed over time when we started saying that disease was based on faith and curse and observational, and how we had progressed over time based on evidence to show that now we're moving along on prevention and precision with the technology and also with the biomarkers. We do have many things to see now that the future generation might involve even personalized prevention plans based on your family history, gene-based therapies, and more importantly, earlier detection and health equity for everyone. Next slide. So I think the take-home messages, in concluding what Dr. Lewis was illustrating very well, was that cardiovascular disease continues to be the leading cause of death in women globally. We thought that it was cancer, but she showed the statistics, and it's something to keep in mind. The second point to keep in mind is there are some risk factors that are unique, especially for women. And those are things to keep in mind, to wonder us, who of our family members or of self at a risk to have those risk factors. And 3, we do have a combination to prevent cardiovascular disease, and it's a combination of both. You take your medications, okay? So you follow the recommendations like your doctor gives you, but it also depends on the lifestyle that you adapt. And I want you to keep in mind that slide with the pillars, okay? With the sleep, with the stress reduction, with the body size, and also with exercise as well. That's the best preventive strategy that we can take. And again, as Dr. Lewis pointed out, we're always trying to understand before the disease develops who is at risk of developing itself. So that's why our modern tools that we're using, either advanced imaging such as the CAT scan that we saw, or the biomarkers that we saw in the blood, who will lead us to be more aggressive in management. Okay, so thank you for your attention and your time, and we're happy to take any questions.
Thank you, Dr. Chavez and Dr. Lewis. That was a great introduction to the evening. And while there are people putting in questions, and again, I want to remind the audience that please use and some of you already are doing it in the chat box. Please put in your questions so we can pose it to our experts here. So let me before you jump into your discussion, let me ask you a question. Dr. Lewis, you mentioned symptoms. Symptoms are different, are not as different. Still, people have chest pain. Majority of the women also have chest pain or some form of chest discomfort. Now, the question always comes up is, how do I distinguish what's important, what's gas, what's something else, and what should, make me go to the emergency room versus urgent care, or kind of sit there and wait till the next day to call somebody? Can you kind of...
Yeah, it's really interesting. And, we both worked downtown for quite a long time. If you have a man that works on the Hill or whatever, and he's sitting at his desk and he gets discomfort or pressure in the chest, what's happening? Coming to the hospital immediately. Women tend to, and this is getting better, but they get a little something in the chest and they go, oh, let me take a Tums, and I got to pick up my daughter or grandson, and I haven't made a trip to the grocery store yet. And these things are really important, and sometimes you cannot tell. I mean, we have emergency room doctors that can't tell if it's a GI problem, reflux, or if it's in fact a heart attack without doing some further testing. So the thing I would say, without being too long-winded, I've had women say, I don't want to go. It's embarrassing. I don't have anything. And I don't want to go to the hospital for them to tell me I don't have anything. If you are concerned that you have persistent discomfort in your chest, and particularly if it's associated with shortness of breath, nausea, sweatiness, or radiating going down your left arm, your jaw, or your neck, you should be coming to the emergency room. And if it is severe and you have particularly some shortness of breath, you should be calling an ambulance. And you should never be concerned about, you know, I don't want to go because I know it's nothing and they'll just tell me I'm being silly. That should never be the case.
No, thank you. No, Dr. Chavez, like just what Dr. Lewis mentioned about the disparities in the sense of how people address those symptoms, and there is a gender-based difference in the prioritization. So, we all know the women serve as the chief medical officer of their families, right? They prioritize everybody else's health over their own. So, what would you say? I mean, you are in that kind of crux of your career. You're going to be taking care of people and helping them live longer and better. What do you think? How can we engineer a care pathway that bypasses this kind of behavioral barrier?
And I think, I think you brought a really good point that, women are often leaders at their homes. So, I think finding a balance between, there's always an old saying that say, first, if you want to take care of others, you have to take care of yourself. And I think this is a basic principle that we have to remind ourselves. And people imitate behavioral, and when you're a leader and you take care of yourself and your symptoms and you address your concerns, I think the people, your children's, your brothers, and everybody that is around you will imitate this behavior and be like, oh, maybe I should be concerned too, or maybe I should start doing the follow. So I think, as you said, unfortunately, we find ourselves when we're leaders in our families or in our communities or in, in whatever work we do, we often don't find the time. But I think, understanding that at least once a week or in a moment, taking a time or a diary about what are my current symptoms, when was the last time I saw a doctor, am I following all my preventive screening by that time? I think it's important. I think the question begins, when was the last time I saw a doctor, and that I took enough time of taking care of myself while I'm taking care of others.
That's great. That kind of actually addresses one of the questions which came up through the, audience chat, is like somebody wanted to know how, without really getting into specifics, because obviously, as you said, seeing a doctor, a cardiologist, so what would you say to somebody who says they've been told that they have some plaque buildup, and who should they be really seeing, and what frequency, at least, do they need to see a cardiologist? What else do they need to do other than changing their lifestyle? Which obviously we have a big focus on in terms of better lifestyle, but what else can they do to take better care about that plaque buildup?
I think, it's important that they see a heart doctor too, because I think what Dr. Lewis was pointing out, we're now, and with the imaging that I saw, is we're trying to make sure that that plaque, one, doesn't progress, and how we can actually make it regress, take care of that plaque. So how often do you see that, depending on the severity, but at least I will say, at least every 3 or 6 months, or at least once a year, to get that sense to see a heart doctor if you're concerned that you might have plaque built up.
So let me just jump in and add one thing before everybody online runs out to get a calcium score and an MRI, Doris. Uh, so there are a couple of things. It is very unusual for young women to have any calcium in their coronaries. The study is a CAT scan, so it's not without radiation. And so I am very cautious about using radiation in young women. The other point I would make is that women tend to have more calcium, which is what that CAT scan picks up. So women tend to have less calcium, than men. It does not mean that there's no plaque. It means that there's no calcified plaque. So I have a lot of people that feel comforted by tests, and I'm not underplaying at all the importance of testing, but a lot of things you have in your own hands. You have to know your numbers. What is my blood pressure? What is my cholesterol? What is my hemoglobin A1C? Do I know about my family history? And am I getting the pillars that Dr. Chavez talked about here? So I think all of those things are just really important. And certainly either your internist or your cardiologist can help you figure out what your risk is and what you need to do to mitigate those risks.
No, Dr. Lewis, you mentioned, some of those tests, especially the calcium score and the discrepancy in women, especially for non-calcified plaque. What would you say? Obviously this is kind of a hot topic right now in all different literature. If there was a one non-traditional risk factor or test you would also consider, whether women with a lipoprotein little a or hsCRP, because there's a lot of stuff comes up online. Any comments on that? Where does that fall in this whole?
I actually like, and Dr. Chavez brought this out, the ApoB. The reason the LP little a is causing me a lot of headaches is that it is higher, as you know, among Blacks. And sometimes I'm not sure what to do with that. I think we need some more studies. Now, it's very clear if you have an elevated lipoprotein A, that it gives you an additional risk factor. But it's not really clear because it's pretty remarkable. I don't know if you've seen the same thing, but those LP A's are quite high. And I just don't know how much risk that confers. So I actually use the traditional ones. I order the ApoB. I have to confess, I don't get a lot of CRPs. I get CRPs when somebody asks me for it because they Googled it. And that's usually where I start. I don't want to understate, though, the importance of the family history. And that turns out to be, if your father had an MI at 52 and your mom had a bypass at 60, those are very significant things. And they would push us to be more aggressive in how we treated, for example, your blood pressure and your cholesterol.
No, that's great. So we talk about family history and risk factors like as such. Now, what about autoimmune disease? We know that in women, women, the prevalence of autoimmune is much higher. So we also know that inflammation has a role in atherosclerosis and plaque buildup. Would you say that a diagnosis of maybe lupus or rheumatoid arthritis is some form of like a kind of coronary heart disease risk equivalent?
I
Something
think,
similar?
well, women have more autoimmune disease, so that's important to recognize. And it is absolutely, that inflammatory process is absolutely a risk factor for cardiovascular disease. So those women should be monitored more carefully. And other things that are unique to women, like I just mentioned really briefly, polycystic ovarian syndrome. And I have several of those people in the practice, those women in the practice, and you need to be particularly careful about managing their cholesterol levels and their hypertension, working towards prevention.
Great. I have a couple of questions coming through the audience. I want to, Dr. Chavez, maybe you can take this one. And, there's a question whether having long COVID portends a future risk for future cardiovascular events. Does that, what's the kind of theory around it?
Yeah. And, that's a great question. And I think that's a question that we often get in clinic too. And, as we started seeing COVID, unfortunately, we started seeing more cardiovascular problems overall. And the concept behind that, it was that COVID leads to inflammation, and we're still trying to understand how much of this inflammation had led to an impact. Okay, but there have been some studies associated that the more times you have COVID, then it does increase, and long COVID itself can also increase your risk. I don't know how much of that will be a risk enhancement as like the ones that we were talking about, but definitely that's something to keep in mind now. Anything that causes inflammation in your body might increase overall the risk of heart disease.
And as people, this is a whole generation which is going to be exposed to this, and people are going to take efforts to change and again risk factors when it comes down to. There's always a question about the lifestyle modification, the diet, the exercise. So there's a question, or actually a couple of questions related to that. People want to know: are there any specific foods? Does cheese or yogurt have any role on calcium score? Or calcified plaque in your coronary. So what do you think?
Yeah, and I think that question comes often too in clinic, and I think there are a couple of diets that have been associated with a better outcome for your heart disease. For example, the Mediterranean diet. The question is why this diet over time had shown more improvement. And, it's heavily on vegetables, olive oil, and fruits. So the concept is trying to reduce certain portions, especially like processed food that has a lot of preservatives, that can increase your risk of heart disease. Also carbohydrates, carbohydrate are highly associated, especially if you have big portions of high carbohydrate. That makes your diabetes a little bit worse, and it makes your diabetes worse, then, it makes worse your heart. So, high fruits and vegetable, fruit, seeds, nuts, some diets such as like the DASH or the portfolio, which are very heavily seed nuts diet, or even plant-based diet now that we have advanced in that had shown an improvement on your heart, and even a reflection in your blood pressure as well.
Any thoughts on processed versus kind of minimally processed?
Yeah, I think the highly processed food, all these components, not only for your heart, but also have been associated with an increased risk of cancer, all these canned foods. Unfortunately, this is a good reminder for all because, we live in such a busy time at work and at home that, we just get home and the last thing we want to do is, prepare a meal. And not even that, preparing like a vegetable food meal, it's also expensive, so just keeping in mind that now there are options for us, and resources available for preparing a healthy diet, that it will take less time, but less processed food. That's also something that you want to look for sure.
And I want to come back to a couple of things. I just want to address a few questions from the audience. And there's a theme about palpitations, and maybe Dr. Lewis, and you have a very extensive experience of taking care. And I think the question is that people have palpitations. They have seen providers. They have a few tests done, and including Zio patch and other monitoring tests or EKGs, and nothing shows up. What do they do, or what do they think about it? Maybe you can shed some words of wisdom on that.
Palpitations just means that you have a sensation in your chest. You feel your heart. And usually I try to get to exactly what do you mean? Is your heart beating fast? Is it pausing? Is it skipping beats? Is it irregular? Or you just feel the sensation of your heart beating hard. So those monitors, first of all, the first thing is to establish that you don't have any underlying heart disease, because there's a very different implication of palpitations with a normal heart versus with an abnormal heart. So that's one thing. But if the monitor, the important thing is if you have the palpitation while the monitor is on, and the monitor does not show anything, your symptoms are not a consequence of an abnormal heart rhythm. So
yeah, I think that's a great reassurance right there. And that the the aspect that, after testing is done and if there's nothing kind of dangerous on there. So thank you for that. Now, obviously, they should definitely be consulting their favorite cardiologist. And with that question comes up is, how do you really find a cardiologist? It's obviously very easy for me to say. I have two amazing colleagues on here. And so look them up and, make an appointment with them. But like for somebody out there, what's a way to find a good cardiologist?
Well, I think the best way is to ask your primary provider, because she or he will have a certain network of people that they're familiar with, and they will hear from patients and how happy or unhappy they are. But I think a referral from your primary care provider is the best thing. If you don't have that, the other thing is everything is online. And you want to make sure that the person, is board certified and has some interests that align with your own. The one thing I'll just make one point. It is very helpful for you to have your health consolidated in a place. I'm spending more and more time with people checking their portal on their phone because they have the eye person here and the rheumatologist there and the cardiologist here and the primary at a fourth place. And I think that can make things very difficult to make sure that you have all that information. Sometimes it's just not possible. But if you can consolidate your care, I think that serves you better.
Yeah. Any thoughts on vitamin D? What about, where does vitamin D fit in like low levels of vitamin D and cardiovascular health? What's the dictum on that?
Well,
Either of you.
if your vitamin D is low, you should get treated. If your vitamin D is not low, there are no good data to suggest that that prevents heart disease. I'm not an advocate at all of supplements, with two exceptions. One is if your vitamin D is low, maybe three. Two, I think magnesium can be very helpful in patients with high blood pressure, in patients that have palpitations, and in patients on a fluid pill, a diuretic. And then there are other circumstances where supplements might be helpful. For example, in vegetarians or vegans, you want to make sure you're checking that B12. But in most people who have a reasonable diet, you get all of the vitamins and minerals that you need. And the rest of it, you can take it, but you urinate it out.
Mhm.
Now, talking about replacement of things, there's a hot debate and everybody has been talking about hormone replacement therapy, HRT. And it obviously confuses everyone, including clinicians. Is it kind of safe to say, or what would you say? Is early HRT protective, or while it's late is harmful? And how would you address that? Or should cardiologists simply advise any advice on systemic estrogen?
Yeah.
Totally.
Yeah, I can wait in. So I know that there had been a lot of debate, as Dr. Panjrath suggested. So I think you should always keep in mind that it should be specific to the patient. Each patient is different, and what applies to you might not apply to someone else. Okay, so if you have severe symptoms, and hormonal therapy has advanced over time and it has gotten better. The ones that we have when we started, it had more side effects and actually have more impact on your cardiovascular disease. But as it gets better, it still had shown, some debatable consensus that you should not be using it in patients with heart disease. I don't know if you feel different, Dr. Lewis, about it, but in general, we always have to know that if our patient has a high risk for heart problems, we should try to be avoiding these therapies
Yeah.
for them, unless, you know, the severity of the symptoms, like at the end, it's all a balance about it. That's why I always say it should be personalized for everyone's risk factors and symptoms as well.
Yeah, it's so the Women's Health Initiative is 15 years old, and those data maybe even a little bit older, and it was a large study in women looking at the effect of hormone, and it really shook people because what they found was an increased risk of clots forming and breast cancer and no prevention of heart disease. But we're not using, as Dr. Chavez pointed out, we're not using those same hormones anymore. And I think that the OBGYN people have a much better armamentarium of what they can use to control the symptoms. So I don't usually, it is really hard to look at a woman that says, look, my sheets are wet in the morning. You know, because you're having all of these hot flashes and it's embarrassing, you're at work. So I think if you're having severe symptoms, one can strike a balance between the lowest dose of the hormone that will control your symptoms, but being particularly emphatic about controlling those other risk factors.
You know, talking about OBGYN and collaboration, I want to put a shameless pitch for our future webinars. We're going to be talking about these issues in more detail. So stay tuned on those topics. And with that, actually, I also want to go back to a question about Minoka, you know, which is also going to be, as you can see on the slide, a topic which we will be talking a little more historically. There was something Syndrome X, you know, Minoka, Anoka. You know, can you know, either of you, Dr. Lewis or Dr. Chavez, kind of deliberate a little bit about what is microvascular disease and why is it more common in women?
Yeah, and you know, I can start with it. And you know, Minoka is that.
Oops. Yes. So I'll chime in here. So when you have individuals, men and women that come in with symptoms, severe chest pain, everybody's worried this is their coronary arteries. If you look at taking these people to the cardiac cath lab to look at their coronary arteries, very clearly women are less likely to have the traditional standard blockages in those blood vessels and get a stent. And so they're more likely to have microvascular disease. And we're finally understanding that that's not the end of the story. If you bring a woman in and she has typical symptoms of chest discomfort, but oh, the cardiac catheterization doesn't show a blockage, that's not the end. They still, you know, the woman still has chest discomfort, and then you need to start considering that it's a non-traditional cause of the chest discomfort. It's not a blockage in those blood vessels.
Yep, and I'm sorry that my connection for a minute, I think you guys lost me, but what I was trying to point out was that, you know, women are at risk, as Dr. Lewis was pointed out, you know, it's all about, you know, there's no blockages in the vessels, but women tend to have a smaller vessel and have to have more tendency to have spasms in those vessels. So that's why they put them overall at higher risk of this Minoka, as what we were talking about. And as you said, you know, they're still having symptoms, so we have to treat them despite, you know, most people saying that they don't have an obstruction.
Well, this has been fabulous. I think, you know, we're kind of coming close to the hour. Let me, you know, before we wrap up and, you know, start wrapping down stuff, let me ask you this question, both of you. If a woman wants to start protecting her heart today, what are the 3 most important things she can do? What do you, each of you separately?
So I think, you know, understanding what your risks are, I think that's question number 1, base what your family, where you come from, and, you know, how are you eating and how much are you exercising? Two, as Dr. Lewis pointed out, you can keep control of your health. You can check your blood pressure at home and bring these readings to your doctor and see, if your blood pressure continuously high, that will impact negatively to your heart. Three, at least see your doctor once a year and make sure that you're checking your cholesterol levels. I think those are the things that you have to keep in mind, in a summary.
Well,
Dr.
that
Lewis?
was extremely well stated. I'm not sure I have a lot to add to that, but I think that it's never too early. I consider it a down payment on your future self. It is never too early to eat healthy. I saw a statistic the other day that something like 70% of calories for the average American is from ultra processed food. That's insane. So starting early, and women often lead the family in what to eat, and putting in regular exercise, because exercising does not get easier as you get older. But if you establish a routine of getting some kind of activity, it's really straightforward. It's still diet and exercise and knowing your numbers, blood pressure, cholesterol, etc.
Great, thank you. And again, for the audience, we will go delve into those issues even more in the future sessions, specifics about diet and a level of exercise. So, final takeaway, each of you, one or two liners, one misconception about women and heart disease that you wish everyone understood.
That women, I get this all the time. Well, women have different symptoms. And they have additional symptoms, but discomfort in the chest, and not often perceived as pain, is still the major sign for cardiac issue. That discomfort is usually, and it's not coming and going pain. That's generally not the heart. It's a persistent discomfort, particularly one that was precipitated by some physical activity or emotional stress. But this thing about women have different symptoms is only in part true. It's only in part true. It's usually chest discomfort.
Dr. Chavez?
Yeah, and one more bottom line, like I said, it's understand your risk, and keeping in mind, and I just want to highlight that again, we have young women who are healthy, but they have, complications during their pregnancy. They were diagnosed with high blood pressure and they delivered their baby and they have preeclampsia. So just keep that in mind, that if you had that event during your pregnancy, because that might be your first encounter as a young woman, to see a doctor. So if you have any of these features, understand that, over time, you should be checking your blood pressure, because the likelihood of developing problems related to your blood pressure or to your heart could be high. So just keep that in mind, understanding your risk.
Well, that was great. Well said. And, thank you, because as we'll see, that's another topic which, I hope the audience will tune in, because we will go into more detail, the risk factors related to pregnancy and, pre and post in our future series. And with that, I think we are just about time to wrap up. And I want to first say thank you to both Dr. Chavez and Dr. Lewis for this fabulous discussion, engaging, really insightful. And most importantly, to the audience, for kind of sticking with us. I know it's peak time, dinner time. Some of you may be cooking, some of you may be having, a cocktail or something. But again, I really appreciate your interest, your participation. We look forward to having you in some of our upcoming webinars. I also want to say thanks to our marketing team and our AV team, who have been really, really great asset for this whole webinar. And finally, to Ms. Susan Duberstein, who's our Executive Director of the Heart and Vascular Institute, who's here as well, joining us. And, if you have any questions, comments, you can always email her. It's on our website. Any specific topics you would want to kind of hear about, talk about, engage in, please send us those feedback, and we look forward to getting them on as well. Again, I hope you have a great rest of the evening, and thank you again for joining us. Have a good night.
Good night.